So I think Divya, you can start.
Yeah.
Hello.
Yeah. Ashish, you're audible.
Thank you.
Good evening. On behalf of the Movement Disorders subsection of Indian Academy of Neurology, we celebrate the World Movement Disorders Day on 29th November every year, and this commemorates with the birthday of the famous physician and movement disorder specialist, if we may call him so, Dr. Jean Mary Charcot. And every year, this day is celebrated to increase awareness regarding movement disorders across the globe. And this year's theme is What Moves You? So we are expected to share our experiences of what actually moves us. So today we have a great session on twists and turns of movement disorders. It's from a physician's perspective. What we basically want to do is what we would like all the physicians, psychiatrists, general neurologists to be part of this wonderful meeting. And we have a host of speakers as well as panelists to share their experiences with you. And without much ado, I think we'll start the program. And let me call upon Dr. Neeraj Kumar, sir, who is the chairperson of the Movement Disorder subsection of Indian Academy of Neurology, to start the program.
Thank you, Divya, for taking all the efforts, and you have designed a very nice program. And I think with all our young movement disorder specialists who are here to guide all of us regarding the movement disorders and how to proceed further once we see a patient of movement disorders, mostly as a physician, or how the challenges which are being faced by the physician. Unfortunately, our President Sir, Lakshmi Narasimhan Sir, and Secretary Sir, Meenakshi Sir, they have some commitments, so they might be joining later. So I think I would like to welcome all our speakers and our eminent panelists for this session, and I hope that it will definitely be a very fruitful session for all our attendees. So maybe Divya, you can proceed further, and we can start. Yes, please.
So as part of the first talk, we'll start with what are movement disorders and how do we diagnose them. Dr. Sneha, could you please share your screen? Yeah. So Dr. Sneha.
Sorry.
Yeah. So Dr. Sneha Dayanand Kamath, she's a young budding movement disorder specialist. She's a very enthusiastic movement disorder expert. She's an attending consultant at KIMS Mahadevapura, Bengaluru. She has done her DM neurology as well as fellowship in movement disorders from NIMHANS, Bangalore. And she has multiple research publications to her credit. So over to you, Sneha, for the first session.
Yeah. Pretty hyperkinetic start from my side. Sorry about that. Once again, thank you to the movement disorder subsection of the Indian Academy of Neurology. I will not waste much time in the introduction part, but to begin with, we will have to introduce ourselves to what a movement disorder is. And going by the second edition of Yankovic's movement disorders, I still recall this definition as movement disorders being neurological syndromes in which there is either an excess of movement or paucity of voluntary movement, which is unrelated to weakness and spasticity. I find this definition to be extremely robust because it helps young neurologists such as myself define all types of disorders that can be categorized as movement disorders without falling into the pitfall of including mimics into this. So there are various categories of movement disorders, and movement disorders form anywhere between 5 to 15% of a neurologist's OPD, depending upon what kind of center we are sitting at. And not exactly in chronological order, but more in order of the spelling. We have anywhere between ataxia, balism, chorea, dystonia, myoclonus, tics and stereotypies, tremors, and stiff person, which has been added more recently. The anatomical correlates of movement disorders, initially being considered only as basal ganglia and its connections, cerebellum and its connections, but nowadays we have come to understand it can extend much beyond that, probably touching even the cortex, the brain stem, the spinal cord, and the peripheral nerve also. So what happens when when we look about movement disorders, is another way of classifying it, which is the etiological, which is primary and secondary. Primary disorders looks basically at degenerative etiologies, whereas secondary disorders basically means that there are other causes for the movement disorder in the form of drugs, infections, inflammation, metabolic causes, vascular or structural causes. So generally, when a patient walks into the movement disorder clinic or a clinic for any person, one very important aspect which all of us do is we take some time out to take a good neurological history. The key aspects of clinical history in movement disorders is very similar to a good detailed neurological history, with some specific emphasis on age at onset, the temporal evolution, particularly in patients in whom there's a strong family history. We have to draw a good pedigree. And in the elderly, when there is like a subacute onset movement disorder, we have to look in detail at the drug history. I Since we are limited by time, I have not focused much on this aspect, but I'm focusing more on the second aspect, which is basically identifying the phenomenology and using the phenomenology to forming the diagnosis. So important questions that we have to ask about the phenomenology during the clinical examination is what, where, when, how, and who. By this, I mean, what exactly is the phenomenology or the movement disorder we are seeing with its full descriptors? Where exactly are we seeing the movement disorder in the body part? When does it occur? Or what are the precipitants? Or what are the, or how does it resolve? And who basically means what are the accompanying movement disorder and non-movement disorder neurological signs that will eventually help us understand what this movement disorder syndrome is. So what am I seeing? This describes basically the phenomenology. Now, a phenomenology or a phenomenology in movement disorder field means a detailed observation of the clinical phenomenon. You see whether the movement is a fast or a slow movement. You see whether the fast movement is jerky or non-jerky. If it's non-jerky, is it rhythmic or is it patterned? If it's jerky, which of the other descriptive characteristics apply? So once again, a more pictorial representation of what I was describing previously. If I see a movement, do I see it to be excessive or do I see it to be fast? In which case, I would define it as a hyperkinetic movement. Or am I seeing it as a paucity of a normal movement or a slowness of a normal movement, in which case I would be defining it as hypokinetic. When I think about hyperkinetic movement disorders from the previous list of movements, I remember various movements like dystonia, tremor, myoclonus, chorea, balism, athetosis, and tics. While I think about hypokinetic movement disorders, I think of Parkinsonism and stiff person syndrome. When I think of hyperkinetic disorders, again, I have to classify them as jerky and non-jerky movement disorders. Non-jerky movement disorders by nature include dystonia and tremor, whereas the rest of the hyperkinetic movement disorders predominantly fall into jerky movement disorders. An important point once you think of non-jerky movement disorders is considering whether this is a rhythmic and oscillatory movement or not. If it is a rhythmic and oscillatory movement, we're thinking a lot about tremor. On the other hand, if it is not rhythmic really, there is like a quasi-rhythmic movement and sometimes what is also known as patterned movement of a limb or a patterned movement at the neck or a patterned movement at the trunk. We can also think about dystonia. In terms of jerky movements, we can think of whether the jerky movement is sudden, brief, and shock-like. It can be a myoclonus. On the other hand, if there are like multiple jerky movements, one flowing into the other, often appearing like a dance-like movement, it is what is known as chorea. Large amplitude proximal jerky movements, which we have all seen in our emergency department, is described as balism, and slow writhing movements are known as athetosis. Stereotypic, repetitive. If the movement is appearing stereotypic and repetitive, then it falls under tics. The next question that we ask ourselves once we have suggested that, okay, look, this is what I think the phenomenology is, it is very important for me to further define the syndrome by saying where exactly I'm seeing it. Now, this is relevant to all of the phenomenologies, but particularly for dystonia, tremor, and myoclonus, there have been newer classification consensus wherein they have identified dystonia to be focal, segmental, multifocal, and generalized. By this, we mean that focal means that only one area or one body part is involved. Segmental meaning that two body parts are involved and they are by nature contiguous or continuous with each other. Say, for example, in a patient who's having dystonia at the hand and fingers, if they're also having dystonia more proximally at the shoulder, elbow, it becomes segmental. If, however, the two areas are not contiguous or not continuous with each other, it becomes multifocal. And once again, if there are more than two areas involved and one of them is axial also, then it becomes generalized. Similarly, tremor syndromes are also classified as focal, segmental, and generalized. But particularly in the case of tremor, we will also consider an entirely unilateral or hemitremor syndrome also. Myoclonus has more varied distribution. It includes focal, multifocal, generalized, hemimyoclonus, distal, proximal, and axial myoclonus. The importance of this being that whenever you see these kind of body distributions, automatically the number of syndromes and the etiologies start narrowing down. So it's very essential to identify where exactly we are seeing this. Now, this is also important when it comes to chorea. You can either have hemichorea or generalized chorea. And particularly when you think about generalized chorea syndromes, it's very essential to identify if the chorea is restricted or is more predominant in the upper face as opposed to the lower face, as it helps us differentiate between choreas like Huntington's chorea as opposed to other choreas like neuroacanthocytosis. So when we move to hypokinetic disorders in terms of distribution, we often think of it as symmetric and asymmetric and axial and appendicular. So when you think about symmetric hypokinetic disorders, we have to always consider atypical Parkinsonism as an important differential. And in addition to that, if it's predominantly axial, we can also consider stiff person syndrome. If, however, the hypokinesia is asymmetric, then the first thing that should come to our mind is typical Parkinson's disease. And also, we should also keep a differential of multiple system atrophy. The third question that we have to ask about ourselves, about the patient to ourselves when we create the syndrome in our mind is, what are the activators? What happens or what causes these abnormal movements to increase? And also, what are the things that can cause it to disappear? So particularly in the case of myoclonus, we know that there is a component called stimulus sensitivity. So a patient walks in with fine myoclonic movements of the fingers, and you can help increase, or you can help make it appear to you by giving a stimulus like a loud bang on the table, or you can also make tactile stimulus by using the back end of the hammer over the dorsum of the palmar surface of the hand. Very rarely, visual stimulus can also precipitate myoclonus. In terms of dystonia, by definition itself, dystonia is considered to be initiated or worsened by a voluntary activity. This is particularly true when you think about focal and task-specific dystonias, wherein when a patient uses a certain activity, his hand to do a certain activity like writing or typing, they may realize that the activity is appearing and increasing, and at other times it's absolutely normal or not there at all. Another thing that we have to see in patients with dystonia, or in whom we are suspecting dystonia, is if there is a sensory trick. Many a times a patient may walk in with their neck supported with the arm like this, so as to prevent a cervical dystonia from becoming very apparent. The moment this sensory trick is removed, the dystonia or the torsion of the neck towards one side or upwards or downwards becomes very prominent. A third thing in dystonia is also mirror movements, but I think the subsequent topics or the talks will help cover these points about dystonia. When it comes to tremor, there are some very peculiar activating factors that we have to look for to help define the syndrome. So first thing is identifying whether the tremor is present at rest. And how do we look for rest is we ask the patient to sit with their hands supported, preferably over a table or over the armrest if one is available. And this has to be in a semi-pronated to fully pronated position. At this point of time, if the patient develops a fine tremor in the fingers, like a pill rolling tremor, which is classically described in our medicine textbooks, then it very strongly points to Parkinson's disease. We can also have tremors coming only when the hand is in a certain posture. So we use two kinds of postures in the clinic. The first posture, as is shown in figure B, is when the patient is asked to keep their hands fully outstretched, fingers relaxed. And at this position, if the patient develops tremors, it can point towards essential tremor, but please make note, there are two caveats to this. The first caveat is, even in patients with Parkinson's disease, after a short latency period of a few seconds, there can be recurrence of the tremor. So this is known as re-emergent tremor of Parkinson's disease. Additionally, in patients who have postural tremor, the absence of other symptoms is very essential for us to make sure that we make a diagnosis of essential tremor. Moving on, tremor can also be precipitated by certain activities. For example, in patients with cerebellar pathologies or pathologies in its connections, during activities such as feeding themselves or dressing themselves, they may find that they're developing tremor. So what we can do is, in the clinic, we can use certain tasks and activities to bring out these tremors. For example, definitely we do the finger nose activity when we are doing a bedside neurological assessment. But if we feel that the patient is having a kinetic and a postural tremor, it is very essential to do something known as a Archimedes spiral, and also a transfer of liquids from about 15 centimeters or a feet height to make sure that we understand what exactly is happening in terms of the tremor phenomenology. The next question we ask ourselves, sorry, this is with respect to tics. Tics, not exactly a question of when it appears or what the activator is, but it is very essential that a patient develops a tic-like phenomenology in the clinic. We have to ask the patient, is there an urge for you to perform this movement? And do you think you can control this for a brief period? Most tics are associated with an ability to control, but thereafter, following that, there is a burst of the tic and the patient has an urge just preceding the tic to perform the movement. The next question about defining the syndrome is, who or what is the company that these movement disorders keep? Movement disorders, primary movement disorders, can keep a company of another primary movement disorder, or they may be accompanied by non-movement disorder related neurological signs and symptoms. These neurological signs and symptoms can include extraocular movement abnormalities, pyramidal features, neuropathic changes. Therefore, a thorough neurological assessment, once we have finished the assessment of the movement disorder, is quintessential. So different types of combination syndromes in terms of two movement disorder pathologies being together are identified. Like, say, for example, in this very good paper from Bhatia et al., Sir has described about tremor combined with dystonia, tremor combined with Parkinsonism. Mind you, these are all genetic tremor syndromes. I would also urge members of the audience to read this paper from Watt et al. In 2019, which describes when there is an isolated upper limb tremor, how to identify and associate them with other neurological or other movement disorder syndromes, and how to identify which kind of syndrome or upper limb tremor syndrome the patient falls in, and how to proceed for the diagnostics. Similarly, dystonia can be accompanied by myoclonus, dystonia can be accompanied by ataxia, and in the presence of these syndromic diagnosis, it is very essential to complete the diagnostic, the clinical diagnostic compilation by looking for oculomotor abnormalities in the younger age group, developmental delay, looking for seizures, looking for prominent bulbar symptoms. And also, moving beyond all of this, we have to also look for some other systemic markers also. Like, say, for example, in patients with ataxia, it would be very critical for us to look for eye signs that would suggest probably ataxia, telangiectasia. In patients with again, multiple movement disorders, but predominantly tremor and dystonia in a young age group, we would also have to look for liver dysfunction. We would also want to look for tendon swellings in certain cases. So this is very important to complete the entire clinical syndrome. So to summarize my current talk, what I would suggest is that whenever a patient walks in with a clinical diagnosis of what looks like a movement disorder, take a good relevant clinical history, which is basically your neurological history with an additional emphasis on the timeline, the family history, and a drug history. Try and define what exactly you're seeing. You may be seeing a hyperkinetic movement disorder or a hypokinetic movement disorder. Try and define the body parts which it is affecting. Try and define the time based, that is whether it is rhythmic or oscillatory, or whether it's patterned and like dystonic in case of non-jerky movements, and in case of jerky movements, look for certain specific descriptors of each of the diagnosis, and also think about the accompanying movement disorder and neurological signs to form the final clinical diagnosis. And when we move from clinical diagnosis to the final diagnosis, I seem to have missed that slide. There are additional ancillary diagnostic tests which we can include, which basically means that we could do an MRI in certain cases to make sure that, like say for example, if we have a hemitremor, to make sure that we've ruled out a secondary movement disorder mimic in the form of a stroke in a strategic area, or if it is like apart from vascular pathology, if it is in case of metabolic toxic parameters, we'll have to look for, and then come to the final diagnosis of the syndrome. With this, I would like to conclude my talk, and thank you for your patience.
Thank you, Sneha, for giving us a good overview of what movement disorders are and how we could look at the phenomenology. And so that's just an overview. And to detail us about what are hypokinetic movement disorders, or where the movements are actually reduced, upon Dr. Vaishak KV. He's a young enthusiastic movement disorder consultant currently working as a senior consultant at the Caritas Hospital, Kottayam. He's a postdoctoral fellow in movement disorders, and his areas of interest are Parkinson's disease, deep brain stimulation, and genetic dystonias and botulinum toxin injection. Over to you, Vaishak, for hypokinetic movement disorders. Could you just unmute yourself?
Yeah. Am I clear now?
Yeah, thank you.
Yeah. So I thank Dr. Divya ma'am for that kind introduction. I thank the office bearers of IA and Dr. Lakshmi Narasimhan sir and Meenakshi Sundaran sir, and also our movement disorder chair, Dr. Neeraj sir, for giving me this opportunity. So without much time, I'll go into the topic proper. So Dr. Sneha has given us an elaborate discussion on how to deal with the phenomenology, what are the different phenomenologies associated, and how do we approach them clinically through a historical point of view. Now we will move on to one of the types of these movement disorders. As she said, we generally classify them into two. And from the as the name itself says, hypokinetic disorders means they are those disorders where the movements are really slow, and it is usually a Parkinsonism where the movements are much lesser than what is expected. And by Parkinsonism, we always mean a symptom. There's a lot of confusion regarding the terms Parkinsonism and Parkinson's disease. Parkinsonism, like we say fever, which can be caused by multiple causes. Parkinsonism is a disease symptom. And Parkinson disease is one of the disease which has Parkinsonism as a symptom. So this is one of the key fundamental things that we have to understand. And now, if you look at Parkinsonism, the characteristic feature of Parkinsonism is slowness. So, to call up a person that he has Parkinsonism, he should be slow in his activities. So, when we can see that when this particular gentleman is trying to tap his hand, he is barely able to do it. And even though he attempts to make initial few taps very fast with a larger amplitude, progressively the amplitude comes down. So, that progressive reduction in amplitude is what is called as bradykinesia, and this is what is the classical signature of Parkinsonism. So to call any patient as hypokinetic and has bradykinesia, we should have demonstrate this reduction in amplitude. Now, is it enough just to have bradykinesia to call a patient as Parkinsonian? No, that is not enough. Along with Parkinsonism, we should also have a rigidity, that is a cockwheel rigidity or the lead pipe rigidity, as we usually say, or we should have a rest tremor. By rest tremor, we mean the tremor that comes when the hand is resting or when the feet is resting or when the patient is walking. The rest tremor can also come when the rest tremor can also come when the patient gets angry, when the patient is assuming a strange situation like facing a marriage or facing a crowd, etc. And the tremor can be really disabling, and there can be action tremor associated with this stress tremor, which will make the patient difficult to do daily activities. And it need not be restricted always to the upper limb and lower limbs. It can also affect the lip, the jaw, the tongue, etc. Now, along with the bradykinesia and rigidity, if they have rest tremor, we can call it as Parkinsonism. So the most essential criteria to call any patient has Parkinsonism is slowness or bradykinesia, along with either rigidity, rest tremor, or postural instability. So this essentially classifies a phenomenology which is a characteristic of hypokinetic movement disorder called Parkinsonism. Now, to approach a Parkinsonism patient, when we suspect Parkinsonism in a patient, the first thing we have to rule out is Parkinsonism mimics. So the patient may be highly depressed and he may not be moving enough. So we have to rule out a depression. The patient may be having spasticity of the lower limb and he may be having walking difficulty due to that, or maybe having a cervical myelopathy with spasticity of both lower limbs and they may be finding it difficult to walk. So we have to exclude all the mimics of Parkinsonism. And when we confirm that the patient has a Parkinsonism, we have to find out what is the cause of Parkinsonism. Dr. Sneha has touched upon this, but for completion's sake, I'll go into that. The most common cause of Parkinsonism is usually Parkinson disease, which can be idiopathic or genetic. And there can be atypical Parkinson disease like progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, etc. And there can be secondary Parkinsonism, which we usually see in clinical practice, which can be either drug-induced, vascular, repetitive infection-related, head trauma-related, etc. So it is important that we identify Parkinsonism as a symptom which has bradykinesia as a predominant phenomenology, and then we classify what is the cause for this Parkinsonism. Now, when we come to the Parkinson disease, the pathogenesis is what every patient comes and asks. Why do we get this disease? It is still unclear, and there are a range of host and environmental factors which has been implicated, with the recent one being microplastics. And if you see these patients, which almost all the clinicians here would have all seen at some point of time, they manifest with different manifestations like hypomimia, decreased eye blink, slow gait, decreased, changed, altered handwriting or altered signature, with which they may not be able to do the bank work, they may not be able to dress themselves, they may not be able to wash they may not be able to take bath themselves or hygiene activity by themselves. So these are all manifestations of the slowness. And along with the slowness, these patients usually also have a myriad of non-motor symptoms. So most of the times we treat these patients' motor symptoms well, because that is what we see. When we see the patient, we'll be able to assess the motor symptoms clinically. But they have a lot of non-motor symptoms, which we, unless ask the patient, they may not come up with always. And if we don't address these symptoms properly, the quality of life may not improve. And there are a host of non-motor symptoms which are there. So these non-motor symptoms usually begin even 10 to 15 years before the onset of Parkinson's disease, and this is called the prodromal phase. Symptoms like constipation, REM sleep behavioral disorder, or enactment of dreams, smell disturbance, or anosmia. These symptoms start 10 to 15 years before the onset of Parkinson's disease. And once the symptom starts, that is the tremor, rigidity, slowness, and the post-instability starts, the patients usually reaches a general practitioner, and they are usually started on levodopa supplementation along with the first visit itself, and then they are followed up, and then they are added on with one medicine to another without proper dosage or titration most of the time. So it is important that we understand how these medications work and what happens to these patients in future. So this is one phenomena that most of these patients develop. This is called motor fluctuation. So when the patient has not taken any medicine, he is slow, we can see the tremor in his both upper and lower limbs. He is barely able to move his hand. and he is barely able to stand. He's standing there and he is unable to initiate a gait. So this is called the off phase, or when he is not with the medicine. And when he takes the medicine, the tremor completely improves and his speed improves, and he is able to stand and he is almost walking normally. So this is called as motor fluctuation. So this is a phase where most of the Parkinson disease patient reach after 6 to 7 years of disease and levodopa therapy. So now we see there are, as I said, there is a lot of medications that is available for Parkinson disease management, but we will definitely brush upon the most important medicine, that is what makes you move. So levodopa makes you move. So when we give levodopa to a patient, there are certain things or etiquettes we should strictly follow, otherwise the patient may not benefit well. So when we choose levodopa carbidopa, the carbidopa is given to inhibit the extracerebral metabolism of levodopa. So the ratio of levodopa to carbidopa should be 1:4 to ensure a proper penetration of levodopa into the brain. So 100 plus 25 combination of levodopa carbidopa is usually the one which has the maximum effect. And to get this drug into the blood, the gastric emptying should not be delayed. So the patient should take the tablet on empty stomach. So most of the times the patient takes the first tablet in empty stomach, but the other tablets they usually tend to take with the meal or after the meal. So that delays the absorption, and there can be up to 30% reduction in the dose. That is, if you give 100 milligram, the patient may have effect of only around 30 milligrams. So 70 milligrams, sorry. So you have to take all the doses of levodopa in an empty stomach. If you don't do that, the patient may not appreciate the good full benefit of the medication. The other mistake that we usually do is when we take a high protein diet along with the levodopa, the branch chain amino acids in the high protein diet competes with levodopa for entry into the blood brain barrier and reduces the effect of levodopa. So we should avoid taking high protein diet in and around after taking a levodopa tablet. Otherwise the effect may not be really good. Iron supplements also reduces absorption. And if some patient is saying that I'm not getting the effect of levodopa after taking it uh, orally or swallowing it orally, you can always ask them to take it along with an acidic media like lemon water or vitamin C or even carbonated drinks. This helps a faster absorption of levodopa into the systemic circulation, and the patient gets his best medication effect as fast as possible. So these are certain etiquettes that we should always keep in mind when we prescribe levodopa to a patient. Now, is prescribing levodopa enough for a patient? No, because when we prescribe twice daily, the patient is happy, is having a very good time for almost whole day. Then we increase it to 3, then we increase to 4, then we increase to 5, and then we don't know what to do. So Parkinson disease is a marriage between the physician and the patient, which will last for his lifetime. So to control that, to make his life healthy, happy, and quality wise good, we should have a definite idea of where we are heading with this patient with the medication after say 5 or 6 years. So it's a long affair with the patient, and it is always recommended that all these Parkinson disease patients are referred to a proper person, a trained neurologist or a movement disorder person at the earliest, so that their drugs optimization can be done well in advance, and further therapy can be planned well in advance. So early referral is always the key. Now, I'll also touch upon certain myths that are commonly there about Parkinson disease. So everybody thinks that Parkinson disease is a single entity with a single cause and a uniform clinical presentation. No, it varies from person to person. It varies with age. It varies with sex. It varies with the type of presentation. Some may not have tremor. Some may have tremor. Some may have post instability. Some may have very early freezing of gait and recurrent falls. Some may not have it. So Parkinson disease is never a single entity. And we usually the general public, when we tell them about Parkinson disease, they usually ask us, so it's a disease that affects older age. No, it's not a disease that affects older age. Even younger people are affected with Parkinson disease, and there is no age limit for that. And tremor is not typical of Parkinson disease. Tremor can be caused by a umpteen number of causes, as Dr. Sneha has elicited. So tremor is not typical of Parkinson disease. Parkinson disease can come even without tremor. And Parkinson disease is characterized only by movement abnormalities. No, it is not movement abnormalities alone. There are other non-motor symptoms which need to be addressed simultaneously. And there is no single diagnostic test as of now to confirm that the patient has a Parkinson disease. If we do a Trodat scan, F-DOPA scan, which are rampantly available now and misused, they don't confirm a diagnosis of Parkinson's disease. They will just tell you that the patient has a Parkinsonism and not that the patient has a Parkinson's disease. Now, the other myth is that genetic testing is of no clinical relevance. No. In patients, those patients with a relevant family history, genetic testing do yield some mutations. And the medical specialist, that is a neurologist or the geriatrician, is the main and the only practitioner necessary for the treatment. No, it is a teamwork between the neurologist, the treating physician, the physiotherapist, the nurse practitioner, the clinician, the caregiver, and the family. So it's a teamwork to take care of a Parkinson disease. Now I'll brush upon atypical Parkinsonism also. So one of the most commonest atypical Parkinsonism is progressive supranuclear palsy, where we have prominent oculomotor dysfunction or eye movement abnormalities, typically the vertical saccadic palsy, and associated with recurrent falls or postural instability. And there is a diagnostic criteria which is well defined for that. And we have the typical MRI change where you have the Mickey Mouse sign and other signs which are described. Now we'll just see one patient with eye movement. So please please see the eye movement. So he is being asked to look to the left and right, and he is able to look to left and right fast. But when he is being asked to look up and down, he is barely. Oh, I'm really sorry about that. Yeah. So he is unable to initiate vertical up and down gaze. So he has a vertical supranuclear gaze palsy, though his horizontal saccades are good. So this is typical of the progressive supranuclear palsy. And this is something which is very interestingly seen in this progressive supranuclear palsy. This is a patient's video in 0.5x or in slow motion. So when the patient is asked to look down, and then when he looks up, his eye takes a roundabout pathway for looking up. So this is called round the house sign, and this is typical of the progressive supranuclear palsy. Usually it will be a much faster movement. This is a slow video taken in slow motion. Now the other thing is multiple system atrophy, where the autonomic symptoms like urinary incontinence, erectile dysfunction, and orthostatic intolerance predominate with a poorly levodopa responsive Parkinsonism or a cerebellar syndrome. And this is a very bad disease with a very bad prognosis. So I would like to end this talk by pointing out some common mistakes that we do. So we should not be using these drugs on a patient with Parkinsonism, or we should be looking out for these patients on a patient presenting with new onset Parkinsonism. That is, suppose if a patient with Parkinson disease comes to the casualty with a delirium and he is highly agitated, we should not be going and giving them haloperidol injection, because that is going to push the patient into a crisis. We should be giving them some sedative like benzodiazepines. And if a patient presents with a new onset Parkinsonism to our clinic, we should be looking at these medications. So of course, we will be looking for the antipsychotics. But what we usually miss is the atypical antipsychotics like risperidone, ziprasidone, lurasidone, etc. And the most oftenly missed compounds are lesuride, which is very usually commonly used for practice on gastroesophageal reflux disease. Flunarizine used for migraine treatment, cinnarizine for vertigo, tetrabenazine, and certain antiemetics. So this list should be always borne in mind when we see a patient with Parkinsonism. For two purposes, we should not prescribe them to people with Parkinsonism, and we should search whether these drugs are being taken by the patient who comes to us with Parkinsonism. And various other metabolic factors are also there which can present as Parkinsonism, which a detailed discussion is beyond the scope of this particular lecture. So take-home messages are Parkinsonism is a disease symptom and it's not a disease. Prompt identification and referral in Parkinson disease is essential for optimal treatment outcome. And we should always look out for factors that worsen Parkinsonism or that induces Parkinsonism, which is important in a general practice. Thank you.
Divya, hello.
Thank you, Dr. Vaichak. That was a wonderful. Hello. Thank you, Dr. Wonderful presentation indeed. You have touched upon especially and also what one needs when somebody has Parkinsonism, and also highlighted what are the drugs that are commonly given in circumstances and which should be avoided. So thank you very much for that.
Thank you.
Divya, I
So
think
next
can
talk.
I will
Yeah,
just
sir,
take
please.
10, 15 seconds. So I think that was an excellent talk, both by Sneha and Vaisak. So Vaisak, very nice talk. Actually, he has highlighted 4 points. I will take just 15, 20 seconds.
Yes, sir.
So if you are 4, 5 points, one is that what he has very nicely highlighted is bradykinesia is the key. So if you have to diagnose Parkinson disease, bradykinesia is the key. So if idiopathic Parkinson disease without bradykinesia never exists. So that is very important. Second point, he has highlighted levodopa always away from meals. So for those our friends who are listening, the levodopa, very nice point. Levodopa has to be given away from meals. It is not a good idea to give it with the meals because of the protein interaction. Third point he has highlighted very importantly. I mean that is what I got from the message, and for you I am just trying to summarize is that drugs are very important. If you see somebody with new onset Parkinsonism, which probably you are a little bit not very clear whether you are dealing with IPD or something, then drugs many times patients will not show you the drugs. So you have to just dig deep, just tell them that what are you taking, give me the details or bring the tablets you are taking. So that is very important. And I think the last point he has given about secondary causes, any patient with young Parkinson disease, always suspect Wilson's disease. If somebody coming to you below 30, below 20, even below 40, always get a KF ring done. So that is, I think, a very important point. And of course, Neha has made the ground for all the four speakers to start with different types of movement disorders. So I think we can proceed further. Divya, please.
Thank you so
I
much.
think one of the very key points Vaishak highlighted is like, especially when people are given haloperidol, especially in elderly, one should be very cautious, especially if you have a subclinical Parkinsonism, it may unmask, or even in the elderly, usually always better to avoid drugs like D2 blockers just for a sedation.
Thank you.
So for the next talk, we have the next talk on hyperkinetic movement disorders. So from the slow movement disorders to the fast movement disorders, let me call upon Dr. Adrish Mukherjee. So Dr. Adrish Mukherjee is an associate professor at the Department of Neurology, Bangur Institute of Neurosciences, Kolkata. He's completed his DM and fellowship in Parkinson's disease and movement disorders from AIMS, Faridabad. He's a young, charming movement disorder specialist, and he'll be here to talk about the hyperkinetic movement disorders. Over to you, Adrish.
So, good evening, everyone, on this World Movement Disorders Day. I'm grateful to the Indian Academy of Neurology, the Movement Disorders Subsection, Divya ma'am, and all my respected teachers and seniors for inviting me today. So, I'll be talking on hyperkinetic movement disorders from a physician's perspective. It will be a 10 minutes talk, so it will mostly be an overview. So there are multiple phenomenologies, so many syndromes associated with hyperkinetic movement disorders. So in 10 minutes, we can have an overview. And even in the age of so many investigations and treatments, it still remains clinical at its core. So most of my talk will be clinical, highlighting the clinical clues and how to arrive at the diagnosis. So, as already told by Dr. Sneha, movement disorders may be hypokinetic, hyperkinetic, or combined. Now, this is the typical pathway that we described. But now we know that multiple pathways may be involved, as highlighted in this picture for tremor. We see at least 4 or 5 pathways may be involved in the generation of tremor. Now, how do we proceed? How do we approach a patient? So, let us not complicate things. So the first thing we have to identify in hyperkinetic movement disorders is identify the phenomenology of the disorder. So that will be a major part of my talk today. Then we have to form a clinical syndrome and we have to investigate accordingly to arrive at the final diagnosis. Now, this is a long list of hyperkinetic movement disorders, but mostly chorea, dystonia, myoclonus, tics, tremor. These are the usual things we get in day-to-day practice, and I'll be highlighting these today. The phenomenology may be broken down if required into 10 points, like the rhythmicity already discussed by Dr. Sneha, the speed, amplitude, continuity, whether it's pattern, the distribution, whether it's present rest or action, or is it task specific, sleep, awake, and suppressibility and destructibility are two additional things we have to note in case of hyperkinetic. I will be showing this. And in addition to that, what we also need to see or inquire about is the premonitory urge and the sensory symptoms. This is associated with tics. So I will not go into the definition or the description of the individual disorders, but I will jump to this slide. So in the tremor classification, so in the axis 1 is the clinical features, axis 2 is the etiology. So in the clinical features, the historical feature, age at onset, temporal onset, tremor characteristic, associated signs. So our goal in these disorders is to see the movement, classify the movement, and see whether it's an isolated disorder or it is combined with other neurological signs and symptoms. Now, this is further into the tremor syndromes. What is mostly maybe what the physicians would see is the essential tremor, but there are nuances to it. And recently, the concept of essential tremor plus has been introduced, where the postural tremor is associated with rest tremor or questionable dystonic posturing or impaired tandem gait. So now let's simplify the classification. Broadly, we can say tremor at rest. Action is postural, kinetic with an intention component, or maybe task specific. So if we see this patient, so we see that this patient has a tremor at rest. This is a patient of Parkinson's disease. And it's present on the right hand. And when the patient puts the arms forward, there is no tremor. This is the Parkinsonian rest tremor. Now we see these two patients. So the right hand patient has a kinetic tremor, and there is intensification of the tremor on reaching the nose. So this is an intention tremor. And in the left-sided patient with the white shirt, that gentleman has some tremor when the arm is at rest, and when he is holding the hands in forward, there is a postural tremor. So it's actually a very long-standing case of essential tremor. Started with postural tremor, and now he has developed the rest component. So maybe we can reclassify this patient at this point of time into an ET plus. This patient is an elderly lady who has this severe tremor. She has rest tremor. She has postural tremor. She has a proximal component to the tremor. She also has an intentional component, and she also has head tremor. So the three components are present. There is a proximal and distal component in this patient. So this is a patient of Holmes tremor. This is actually a patient of post-stroke Holmes tremor. Now, when we see a patient of tremor, it's essential to look at the additional movements. So in the gentleman, we see that there is dystonic posturing of the upper limb, and this is actually a patient of Wilson disease, both referred as tremor to us. And in the lady, we see that there are myoclonic jerks occurring, and this was actually came out to be a patient with myoclonus ataxia and tremor syndrome. So we have to look at the additional movements. Now we know that the speed, it may be classified from the slowest to the fastest. Now if we jump to myoclonus, so these are both our patients taken from the ICU. The first patient is that of a multifocal myoclonus. And what is happening in the second patient is actually negative myoclonus or asterixis. The first patient had uremic encephalopathy, and the second patient had respiratory failure. So this is a series of various patients showing different stages of the same disease. This is actually commonly seen in our country compared to the Western world. And we see that in addition to the limb jerks, there is also, as we can say, maybe a jaw opening myoclonus. And this is what we see in case of SSPE. Now, this is the patient with hemifacial spasm. So this is now classified in the peripheral movement disorders. And this hemifacial spasm, when we see, we investigate, and we treat these patients with botulinum toxin injection with good response. This is the patient after the botulinum toxin injection with near normal functioning. Now, if we go to the amplitude from the smallest to the largest, we see on one side it is Balism, and on the other side it is So the girl has a mini polymyoclonus, and the lady has a hyperglycemic state, and she is having hyperglycemic hemichoreabalism. And the gentleman has a post-stroke hemibalism. He injured his leg, and we had to treat in as an emergency fashion in these cases. So balism is when we get this proximal component, this flinging component, then we call it as balism. So this lady and the gentleman, I'll play the video again. If you see the movements, these are violent movements, large amplitude movements, flinging movements. So this is balism. Now we go to chorea. So when we say chorea, we use a lot of adjectives: irregular, non-rhythmic, quasi-purposive, flowing from one body region to the other. Now, if we see chorea patients, we also have to note the distribution of the chorea. So both these gentlemen are patients of Huntington's disease, genetically proven. And so these are the flowing movements, and the middle gentleman will try to adjust his shorts as if he was doing that. So that is quasi-purposive, trying to hide his movements. But most interesting is perhaps this girl who was actually being treated in the psychiatry department for behavioral issues, and she had only these movements, these eyebrow movements. So these are the only movements seen in this girl, and she also came out to be genetically proven patient of Huntington's disease. Now, this is the classical case of chorea, classically described. So present in children, chorea may have a hemichorea presentation also. This is interesting to note, a non-structural cause of hemichorea. So this is, these two, both children have Sydenham's chorea. This is perhaps rare nowadays. So in the boy, we see the flowing movements of both the limbs, right upper and lower limbs. Now we go to dystonia. This is again the recent classification of dystonia. In the axis 1 is the clinical characteristics, and in the axis 2 we have the etiology and pathogenesis. Again, if we try to, now recently 2 components have been added in the tremulous dystonia and the jerky dystonia. But to simplify this, we can say that dystonia, according to the body distribution, focal, segmental, multifocal, generalized hemidystonia, and according to temporal pattern, this is the least we must see in every patient. So it's persistent, action specific, any diurnal variation, or whether it is paroxysmal. So this is a patient of focal dystonia. This is blepharospasm, where the eyelids are getting shut. The second patient has this jaw opening movement. So she has oromandibular dystonia. Also, there is lingual dystonia in this patient. And this third patient has generalized dystonia. He was gene positive. I won't go into the details. With severe, so we have focal dystonia, we have segmental dystonia, and we have this generalized dystonia. But that is not all. Sometimes we get such patients where the movements, the dystonia, the tremulous movements are activated only while writing. So this is what we call as a task-specific dystonia. So this, again, this is a long-standing case. This started with difficulty in writing. Now this has progressed to this level. So this is a patient or task-specific dystonia. Now another clinical part, when we look at dystonia, we look for the tricks or the gest antagonist. So this is what, so the girl has a cervical dystonia. Now she touches the neck to relieve the dystonic movement. So this is the sensory trick in this girl. See, she is again doing that. There is temporary resolution of the movement when she is doing that. The second patient is actually a post-stroke patient. Whenever he will be using the right hand to touch, to write, or to even lift the pen, look at the mouth of the patient. So now the mouth opens. Right. Whenever he's trying to use the pen, there is a dystonic limb, and whenever he's trying to hold the pen or write with, use it, the mouth is opening. So this is actually a patient of a post-stroke movement disorder with an overflow dystonia. We reported this patient as a limb to cranial overflow dystonia. And this is what we call the mirror dystonia. So when the patient, again a patient writer's cramp, when he is writing with the better hand, the left hand, see the fingers of the right hand will start to move and there is flexion. So the dystonic hand is flexing when the non-dystonic hand is being used. So this is what is we call the mirror dystonia. Now this girl presented to us with these movements. It occurred suddenly when in the railway station, when riding a bike, and it persisted for minutes and sometimes for an hour when she was actually admitted. And she was diagnosed as a, but in between she was absolutely okay. She was diagnosed as a patient of paroxysmal dyskinesia, non-kinesogenic type, and it was again gene positive. And she is not doing well with treatment. Now this boy, 8 months history, previous history of jaundice, presenting with these movements. Now we will go to the next step, whether any clinical clues can guide to the diagnosis. We know this child has dystonia. Now what next to do? Clinically, I'm telling again, before we rush to the investigations. So if we see the limb dystonia, but there is also a jaw opening. See, there the jaw is opening a little. There is a, if you say it's a vacuous smile, right? So we will again come back to this child later on. Next is what we look for, suppressibility. So tics, we know it's suppressible. We usually classify into motor and phonic tics. So the sounds, again, it may be simple or complex. I will not go to the details of everything. I will just show a few videos to show. So these are, so the two patients, two children with tics, motor tics. And actually the right hand boy, he had to be admitted for these head snapping tics as an emergency to the emergency department. Sometimes he had violent head snapping tics. See, again, the boy had a blinking, the left, again, this neck movement system. So, has multiple motor tics. Now, if you look at this girl, sorry, so she will also have, if the sound is playing, right. So, this child has also phonic tics with motor tics. And she was diagnosed as a patient of Tourette syndrome. To diagnose Tourette syndrome, we need at least 2 motor tics and 1 phonic tic. Age of onset less than 18 years, persisting for more than 1 year. And she again responded well with treatment. She's actually doing well. Now this is another movement where you see that the same type of movements are getting repeated and repeated. These are non-goal directed movements. These are what we call stereotypy. Again, stereotypies are usually distractible movements. So if you distract the child, then the stereotypy may be relieved. The first child is a patient of Rett syndrome. The second child is a patient of Wilson disease. And the third child is a patient of anti-NMDAR encephalitis. Now, this is, I think, a question was also asked regarding functional movement disorders. So I will just highlight this patient. This patient has an acute onset tremor. He suddenly one day developed this tremor and was admitted in the emergency ward. Before we could see the patient, an IV cannulation was done. This was the tremulous movement. You can see the tremulous movement. There is some posturing. Now, so when he is doing the movement, the tremor is gone. So there is a little bit of distractibility. There is also inconsistency. So distractibility and inconsistency are markers of a functional tremor. And something interesting will happen at this stage. If you see the tremor, so he will be asked to tap. Look at the right video. So now when he will be moving the left hand, something will happen to the, look at the frequency and amplitude. So when we see tremor, we see the frequency of the tremor. See, the right hand is now moving almost in sequence with the left hand. This is rarely seen, but this is what we call entrainment. So if we get these things, we think of a functional tremor. So now what are the other things we have to see? The eyes. So in that child, he had this KF ring, the Kaiser-Fleischer ring, and clinically we could diagnose the patient as Wilson disease. And in India, any young patient with any movement disorder, we must rule out Wilson disease. That's a dictum, as Neeraj sir has already told us. Okay. So what is this child having? So the first child has a generalized dystonia and he also has an oculogyric crisis. And the right boy has actually a patient of opsoclonus myoclonus ataxia syndrome. The eyes were the clue in this child. See, the eyes, there are very, so this is opsoclonus. Right. So I will just, okay. Now this is the patient who presented to us again with movement disorders, but when we examined the gait of the patient, the gait was like this. And the patient also had proximal weakness. So now the other neurological signs and symptoms are giving us a clue. So in this patient, we diagnosed as a patient of myopathy with extrapyramidal signs, and it was genetically proven case of MICU1. So investigations, once we have clinically examined, I will not go into the details, we will investigate accordingly. In hyperkinetic movement disorders, we have to follow this rule. We cannot send everything for every patient. But again, I will reiterate, in India, Wilson's disease should be ruled out. Now, genetic study, imaging, basic labs, SCAR panel, everything may be sent. And in India, the other thing is that we can send the CSF panel. I will show two cases for that in my last slide. Now, what is this in neuroimaging? This is a typical sign. This is the eye of the tiger sign seen in PCAN on MRI. Now, these are the treatment. I have just summarized this. For dystonia, botulinum toxin; for focal and segmental dystonia, anticholinergic drugs, baclofen; generalized dystonia, refractory to medical management, we can go for deep brain stimulation. And this is the list. What I will again highlight for tics, number one, first line treatment is not pharmacological, it is CBIT, behavioral therapy. Then we can add aripiprazole, pointer, risperidone. This is the overall approach we follow. We identify the phenomenology in mixed movement disorder, combined phenomenology. We look for the predominant movement. Then we look for the combined movements. We identify the pattern of involvement, distribution, etc., relevant history, age of onset, etc., demography, associated neurological signs, as I've already showed in the eyes, in the gait, and so on. We form a provisional diagnosis, then we send for investigations, and then we arrive at the final diagnosis. Now, why I have written response to treatment, I will show in one case. So this is what the heading is: do not miss the treatable disorders. So this boy came to us with, so in the afternoon when he was playing, after running and playing for a while, he had this difficulty in running and walking. So there is some interning of the feet. He had some dystonic posturing examination. This was a child of DOPA responsive dystonia, again genetically proven. So that is, he improved to a low dose of levodopa. And this patient presented with altered sensorium and with this perioral dyskinesias. This patient came out with an anti-NMDR and positive encephalitis. He also responded to treatment, but with incomplete improvement. These are so what are the other? So Wilson disease, autoimmune encephalitis, dopa responsive dystonia, we should not miss in the treatable disorders. Last, I will show these two patients. Sorry. Right. So in hyper, we need to have a drug history, a thorough drug history. So as I have shown in the approach, we need to have a thorough drug history also. The first patient was a tardive dyskinesia. The second patient was a levosulpiride-induced tremor. So this will complete our clinical approach to hyperkinetic movement disorders. Thank you so much.
I think. Divya, so we can move to the next talk, and the next talk will be by Divya MR. I think Ashish. So Ashish, please, you can start your talk.
Thank you, Adrish, for that wonderful presentation. So next, I will call upon Dr. Ashish. So Dr. Ashish is a consultant neurologist and movement disorder specialist at the Bilal Amin General Hospital, Vadodara, Gujarat. He has multiple achievements to his credit, and his areas of interest are movement disorder, stroke, headache, and medical education. So over to you, Ashish. on the talk on when to refer to a movement disorder specialist.
Yes, my slides are visible.
Yes.
Ashish, please go ahead.
His bandwidth is too low.
Ashish, you are there? I think we lost him, Divya. Connection issues.
So what
Ashish, should I share the slides? Hello?
I think he might be having some connectivity issues, is it?
Ashish, shall I share this? I have his slides actually.
No, you can share him, but he should be there. I mean, maybe
Yeah, I will share his slides.
Traveling or something.
Yeah,
maybe Divya, we can if we can see if Ashish it's taking time, then we can start with a panel discussion, and we can just stabilize the connection if it is a problem there with Ashish. Oh, I think slides are playing quite well.
I'm sharing those slides actually.
Okay, so I think
Yeah, Ashish,
Ashish.
are you there?
He has not joined.
Okay, Vaishak, if you can just inform him, we'll do
Yeah,
that
yeah,
after.
I'll just call him. Yeah.
You can, we can ask him to do after the panel discussion, maybe then. I can share the slides, he could talk. Okay, so I think we could move ahead with the panel discussion and Ashish can join in the meanwhile. So we move on to the panel discussion. And I think before that, should we take the questions on the chat, sir?
Please go ahead. We can have maybe few questions. And I think many of our experts, they have already answered, like Adrish and Vaisak and Sneha, they have answered few of the questions already. So we can take if there are any in the chat box, or if anybody has any question, at least we can take 2, 3 questions.
Yeah. Okay, there were a few questions in the chat box. I think one was how do you identify malingering movement disorder? I think Sneha has already answered that if there is a variability, suppressibility, and a secondary gain, you could think about malingering. And functional movement disorders is different from malingering, and it's not actually malingering. Functional movement disorder, we are not really sure if there's an organic basis to it, but that is more of a debatable topic. But malingering is definitely the one which has a secondary gain. I think that's the only question we have currently on the chat box.
We can move quickly to the panel discussion,
Yeah.
Divya.
We'll move quickly to the panel discussion. So let me just introduce the panel. So can you see my slides?
Yeah, they're visible.
Yeah. So to moderate the panel, I invite Dr. Neeraj Kumar. He is the chairperson of the Movement Disorder Subsection of Indian Academy of Neurology. He is a professor and head of neurology at AIMS BB Nagar, Hyderabad. And myself, Dr. Divya KP, additional professor in neurology at SCJMST, will be hosting the panel discussion. In the esteemed panel, we have Dr. Neema B. Karthikeyan. She is the HOD and consultant physician, Department of Medicine, General Hospital, Trivandrum. Dr. Ajit Cherian, who is the professor, Department of Neurology, Sri Chitra Tirunal Institute of Medical Sciences and Technology. Dr. Divya MR, who is the associate professor, Department of Neurology and Movement Disorder Specialist at AIMS, New Delhi. And Dr. Kuldeep Shetty, who is a consultant neurologist and movement disorder specialist at Narayana Health, Bangalore. So we'll just move on to the questions. I think Dr. Neema, I think I will ask you the first question. So I think the most important part of this entire program is the physician, psychiatrist, and the general neurologist. So, as a physician, Dr. Nima, I would like to ask you, in your daily practice, what are the challenges that are faced by the physician in the identification and and management of Parkinson's disease?
Good evening, everyone. First of all, I would like to thank the Indian Academy of Neurology, the Movement Disorder Subsection, and Dr. Divya KP for giving me the opportunity to attend this discussion as a panelist. The question asked to me is regarding the challenges which are faced for the diagnosis and management of Parkinson's disease. Actually, Dr. Vaishak has given us a very detailed description about the cardinal features of Parkinson's disease and how to diagnose and how to manage. So, as a physician, myself as a practicing physician, and before that, I would like to thank for giving the name of this discussion itself is Twists and Turns of Movement Disorders from a physician's perspective. So, as a practicing physician, how to the challenges faced for the diagnosis is the diagnosis of Parkinson's disease is the first question. So, as we all know, multiple symptomatology, multiple myriad of symptoms will present to us. So, the patient will have maybe during the early patient will be having subtle symptoms only when they are presenting to a physician. Usually, the physician acts as the interface between the patient and consultant neurologist or the movement disorder specialist. So it is very difficult in the early stages itself to diagnose Parkinson's disease because in the initial stages, there may not be any motor symptoms at all. So initially, there may be the patient will have only some non-motor symptoms only. Later, only the patient will be presenting to you with the cardinal features of tremor or bradykinesia or rigidity. So as Dr. Vaishak has correctly pointed out, when the patient is coming to us with bradykinesia itself, we should have the suspicion of Parkinson's disease in our mind, and a detailed history taking and a thorough examination of the patient is very important. So other points which require mention is we have to correctly ask for any particular drugs which the patient is on, or whenever we are trying to prescribe some sort of drugs for this patient, like we usually think about this atypical antipsychotics, but as he has correctly pointed out, drugs like lesuride or flunarizine or cinnarizine for that matter, all that can precipitate even a subtle type of Parkinson's disease present. Then the patients will from the history itself, we have to ask about so many metabolic conditions, other toxins, or any other chronic liver diseases, etc., can also present as Parkinson's disease. So such sort of patients will be coming to us as physicians early itself. And so a thorough history taking and a thorough examination has to be taken properly. And as I said earlier, because of this multiple symptomatology present, it's very difficult to diagnose Parkinson's disease at an early stage itself. But we have to keep our eyes open and to try to diagnose the disease. And our discussion early, which was supposed to happen, was when we should refer the patient to movement disorder specialist. So the appropriate time of that, we will come to that discussion later. The appropriate time of reference is also very important. So coming to the and also we know that there is no particular imaging modality or particular biomarker for diagnosis of Parkinson's disease. So it is always the history, and also
I think
the
that's a
patient may require.
great point madam has raised. I think thank you, ma'am, for your valid point that appropriate history and examination are the key to
Key points.
reaching
Yes,
to a
sir.
diagnosis. So I think we go straight away to next question to Ajit. Dr. Ajit is there. So Ajit, probably you may like to guide us, or you may like to guide the senior physician who has diagnosed Parkinson disease. And then the question comes like, shall I continue treating, or I should refer it to the movement disorder neurologist or movement disorder specialist? And when should I refer to a movement disorder specialist? So how can you guide our physicians on that, Dr. Ajit? Ajit is
Yes,
there.
sir. Yeah,
Please.
I'm here. I'm here.
Please. So
Okay.
now, briefly, as always, you are to the point. Just you enumerate a few important points which directly go as a bullet points in physician's memory. So please.
Correct. If you are able to diagnose Parkinson's disease, this is my take home. If the patient is more than 65 years, you can start the patient on levodopa. If the patient is less than 65 years, I often start the patient on a dopa agonist. My preferred drug will be pramipexole, and I have stuck to that. And then as the disease goes on, there is no need to keep increasing the drug at each point of his visit. Ask him how he is able to take care of his daily living. If he is able to do that, there's no need to push it up. And once the disease worsens, you slowly push it up, and always keep in mind that you need to take it 1 hour preceding your daily meals. So this is the most important thing. And avoid all other the nutraceuticals, mainly vitamins, which can interfere with its absorption. The second thing is, as time goes by, you have these motor fluctuations, and that is the time I think you better refer to a neurologist or a movement disorder specialist. All said and done, I was a physician before I became a neurologist or a movement disorder specialist, but I learned how to properly treat this disease only once I had the training under Dr. Asha Kishore. That has to be told in black and white, because at the physician level, it is very, very difficult for us to get the niceties or the finer aspects of treatment. That is one thing which we all need to keep in mind. Okay, thank you.
Perfect, perfect. So I think what Ajit wants to convey to all the physician friends, that probably what you can do is, you can, as soon as you have a suspicion, you refer to a neurologist, and the neurologist makes a plan, and then of course you will be the most integral part in the plan. You will be following the patient maybe monthly, but at least once in 6 months you let the neurologist have a say on that. And if he makes any changes, probably it is easier for you also to be take part in that plan. So I think Divya can take up the next question. Thank you, Ajit, for the crisp reply. Thank you.
Yeah. So Dr. Kuldeep, you are into deep brain stimulation and the advanced treatment options for Parkinson's disease. So I would like to ask you, what are the advanced treatment options for patients with Parkinson's disease other than the drug therapy, and when would you consider that?
Thank you, ma'am. Am I audible?
Yeah.
Yes, yes, you are on.
So I think
No, you were
No,
audible. Now
Kuldeep,
we've
you are
lost you.
audible. We are
You were audible, but you're lost.
am I audible now?
No, not
no.
really.
Hello, Kuldeep. Have you unmuted?
Yeah, he's unmuted, but
Oh,
we could hear you at the beginning. But
maybe,
yeah, without the headphone also should be fine.
yeah. Kuldeep? Maybe Ajit, we can put that question to Ajit, and Kuldeep can take the next one.
Okay.
Yeah,
I
Ajit, please go ahead, I think.
Okay. So, so when do you take this patient for a DBS? I usually suggest DBS to a patient when they start having motor fluctuations and they start developing dyskinesia. That is when I start priming them. So at the first prime, obviously no one is going to take it, and maybe in another 6 months or 12 months they will come. So what is the cost? That's how we slowly build up that rapport, and I guide them to the social worker. So the main rationale is basically, so DBS helps you to reduce the dose of levodopa to a significant extent, and the dose comes down to almost like one third that he was on prior to DBS. So, and then the dyskinesia part comes down, and you get a smooth course of another 4 to 7 years at least once DBS is done. So this is regarding Parkinson's disease per se. And if you are looking at apomorphine, my experience with apomorphine is rather limited because of the high cost involved, high monthly recurring cost which is involved. So I don't know whether Kuldeep, do you have any
Yes,
cases
sir.
of? Yeah, you have.
Yes, sir. Sorry, thanks for taking my
Perfect,
question. Am I audible
perfect.
now?
Yeah, very
Yes,
well.
yes, yes.
Yeah. I think I wanted to make one point, sir. So I think the physicians should know that DBS, apomorphine, levodopa gel, phospholevodopa, these are all glorified symptomatic treatment. I think we should accept this. Physicians should know that there is no magical cure for Parkinson. Disease modifying therapies are not still available. So I many times get referrals telling that you go to him, your Parkinson will be cured. So the expectations from a DBS and apomorphine, all these are very sky high. I think that is something which the physician should know. Even after DBS also, or even after apomorphine infusions also, there are so many unmet needs we need to know. We are probably trying to give a decade of a better quality of life as compared to non-DBS. And in addition, we should also know that there may be some new issues after doing DBS and all. So overall, it's a slightly better quality of life, but it's not like cure. So that's one thing physicians should know. So please refer that, tell that your quality of life may be slightly better with going for these advanced therapies. And I think that should be the referral. Regarding the apomorphine infusions, I do not have patients who are on continuous infusions, but I have tried apomorphine injections. The problem with this is the technical challenge in giving the pump throughout the day and keeping it actually affects your it tends to affect your mobility as well as your there is a lot of logistical issue in keeping a infusion continuously, changing the infusion the lines continuously and all. But all said and done, I think apomorphine should be kept as, most commonly it should be kept as a standby option in patients in whom you cannot offer DBS, or in patients who are yet to decide about DBS. They have not decided, but they want to try something else. They have very bad motor fluctuation. I think in those patients, as well as another handy situation is wherein I think when patients are suddenly off medications due to some reason, some patient who is not been able to take orally, like patients in ICU whose absorption is affected, there I think it comes very handy as a rescue dose. I think this is the thing. But all said and done, it is always very risky to try apomorphine without a challenge.
That's
So
perfect
ideally,
answer. I think you
yes.
have already answered very nicely. The first sentence you told it's a glorified thing and very to the point, and you have very nicely answered that it is more likely as a rescue therapy, apomorphine, and DBS you have answered. So I think we go to the next question. Divya, MR, your take on exercise and diet in Parkinson disease.
Sure, sir.
Divya?
Thank you so much. Both exercise and diet are integral part of Parkinson's patients'
And we
prescription.
request you directly to be to the point.
Yes. So for the exercise, the recommended is like a high intensity to moderate intensity aerobic exercises are actually proven to improve the motor score, gait, posture, and balance. So the recommended is to get at least 30 minutes exercise, at least 3 times a day, and whatever exercise you are able to do, but take care that to do it during the on time, and also be aware of your comorbidities like orthostatic hypotension, cardiac comorbidities, or other situations, and to be better done under the supervision of a physiotherapist. So it is very well recommended to slow the motor progression and has a potential for neuroprotective, and very well recommended like a pharmacotherapy. Whereas the diet, again, the recommended is the diet rich in Mediterranean ingredients, and also the DASH diet, combined form of diet. So you have to take a diet rich in whole vegetables, then antioxidants, fruits, and with the low fat and high lean protein. So this is again shown to reduce the progression of the disease, and to modest amount improvement of the motor scores. But I want to stress upon one thing in the diet already discussed, that you should take the levodopa treatment away from the meals, because protein interaction can cause reduction in absorption. So you have, try to restrict your protein intake. You have to just redistribute. Maybe you can actually push the protein intake towards the evening, where you can have more motor benefits of levodopa towards the morning. So that's about the diet and exercise. Back to you, sir.
Perfect. Divya.
I think that was a quick and a very apt reply. So, Dr. Kuldeep, what are secondary movement disorders, and when should one suspect them?
I think I'll give a very quick answer. I think anything acute or subacute, when you have come across acute or subacute movement disorder, unless proven otherwise, it is secondary. So I think this is one very easy thumb rule one can apply in clinician. Whenever a patient comes with acute movement disorder, I am usually very happy because I know that probably this is something reversible or something. When you come with chronic movement disorders, I think, and pure movement disorder and chronic history, that is when you can think of a primary movement disorder. I think this should be enough. Among acute, of course, drugs. So you can divide it simply as MRI positive and MRI negative. So MRI positive, easily it can be picked. The radiologist will help you with the diagnosis. MRI negative, I think drug is the first thing and go into the labs. And if there is a systemic cause, it will be obvious with the history. So I think this can be a oversimplified version of secondary versus primary movement disorder.
Very nice, very nice. I think so. Kuldeep has very nicely said acute and subacute movement disorders must rule out this secondary causes, especially drugs. Of course, he has not said that if it is chronic, it cannot be secondary, but then of course it is less likely to be secondary. So I think we with this we move on to Divya again, and Divya will help us know about drug-induced movement disorder. So Divya, can the drug can cause movement disorders, and what are the pointers? Maybe you can tell us 4 or 5 pointers which tell us about that this movement disorder is from the drugs.
Okay. So first question, yes, drug can definitely cause movement disorder. It like lot of drugs can cause. Earlier we thought it is only the antipsychotic, and we thought it is only the first generation antipsychotic. We know that now no antipsychotic actually free of risk. All antipsychotic can cause, but yes, a few drugs like clozapine and quetiapine has less propensity. And the newer emerging ones are the prokinetic or anti-emetic that Dr. Vaishaga has shown, like, and Adrish has shown, levosulfuride induced movement disorders, which are very much common these days. And other group of drugs are like calcium channel blockers, anti-epileptic, antimicrobials, antidepressant, mood stabilizers, and even cancer chemotherapeutics. So no, like the list is quite exhaustive. And how to determine? So whenever someone present with a new onset movement disorder, you have to always, whether it is for long duration, acute duration, or like for weeks or months, you have to check the drug list for sure. You have to look at the medication chart and have to check the pill box whether they are taking any culprit drugs. So it can be new drug, or it can be an increase in drug, or it can be just change in the pharmacodynamics. For example, patient is taken another drug which change the metabolism and cause a new onset movement disorder. So the temporal correlation is quite important. Sometimes it may be just supplementation, like vitamin supplementation, or it can be hormonal intake or over-the-counter medication. So when the patient presents with this temporal correlation, then look at the phenomenology. It can be an acute movement disorder. Patient can present with an acute akathisia, that means inner restlessness at movement. And it can be an acute dystonia with oculogyric crisis, neck dystonia, jaw opening dystonia, or jaw closing dystonia, or it can be present subacutely as a Parkinsonism syndrome. So there is no exact clinical point, but people say that, or literature says that it may be a symmetric Parkinsonism without much tremor. But in my experience or in literature, the tremor and symmetry will not help you to differentiate whether it is a drug-induced Parkinsonism or whether it is a degenerative Parkinsonism. And again, chronically also drugs can present. Then you will get the classic presentation, which is called a orobuccal lingual stereotypy, where you have repetitive movement of the face, the tongue pushing in and out, and there may be some like this movement where tongue is pushed against the cheek. So when you see such movement, you have to think that the drug may be a culprit. And if the patient presents with chronic movement disorder, if drug is culprit, you can even have a retrocolis type of dystonia. And again, if you see a patient with multiple movement disorder, you think drug may be a cause. The same patient can have tardive dyskinesia, can have dystonia, can have akathisia. So in any movement disorder, I would say you have to think of drugs and you have to check the pill box or medication chart.
Yeah. Thank you, Divya, for that wonderful description and reminding once again that you have to always check the pill box without any exception. So coming to the most, one of the very pertinent questions, Dr. Ajit, should trihexyphenidyl be given in all patients with D2 blockers or antipsychotics as a prophylaxis, or once the patient has started with the disease? Would you advise starting prophylactic triaxiphenidil or any anticholinergic for that matter?
No, my answer is straight away no. It is one of the most absurd combinations which is currently available in the market. In fact, two very important associations. One is the American Psychiatry Association and the British Association of Psychopharmacology have given written guidelines saying that this combination should actually be banned. The reason is because who develops extrapyramidal side effects when exposed to D2 blocker? Many studies have shown that it's a wide range. It ranges from 4% to as high as 60%. So why this high range difference? So there are certain subgroup of individuals who are more prone for, especially older patients, female patients, patients who are on the older generation of D2 blockers like haloperidol, patients who are having other comorbid factors like AIDS or already a pre-existing dementia. So these subgroup of individuals have a higher risk. And if the cohort had had these subjects, obviously your patient developing extrapyramidal side effects on D2 blocker will be higher. Whereas when studies have been done with the younger patient group with newer D2 blockers, the risk have been found to be very, very less. In fact, it has ranged from 4 to 23%. Now, if you're adding a triaxiphenidil, you are exposing 96 to almost like 77% of these patients unnecessarily. So that is the rationale. And the triaxiphenidil is not a drug without any side effects. It causes a significant cognitive decline as day advances or week advances with exposure to the drug. Now, what is the rationale? What is the ideal methodology if a patient who is on D2 blocker who develops a extrapyramidal? First of all, reduce the dose. If a patient develops ataxia on carbamazepine, you don't. The best option is to reduce the dose of carbamazepine. Patient develops a hyperammonia on valproate, slightly reduce the dose. So similarly, reduce the dose of D2 blocker or shift from the older generation to any of the newer generation drugs. And currently, we have a drug called as pimavanserin, which is quite a very good drug, which doesn't affect any of the D2 mechanism. It has got an entirely different mechanism of action. And what will triaxiphenidil stop? Triaxiphenidil will work only for the tremor part. It doesn't have much impact on the bradykinesia or any of the other extrapyramidal effects. So exposing an individual just because he is on D2 blocker to triaxiphenidil is the worst thing that one can commit. So whenever I am given a podium in a psychiatry association, I always tell them, please stop exposing all your patients to triaxiphenidil. That's actually a sin that you're committing. That's my answer.
Go to the last question, Divya.
Yeah.
Yeah, so the last question, I think we will just take a quick 2-3 line reply from Dr. Neema that how can movement disorder forum or Indian Academy Neurology help you in addressing the challenges which you are facing in patients while dealing with patients of movement disorders?
Okay, thank you, sir. Actually, this vast topic of movement disorders has been presently presented in a very concise manner and very crisp and clear manner by all the faculties. So this sort of discussions are actually eye-opener for the treating physicians and also general practitioners and psychiatrists and everybody. And also regarding the newer modalities of management also is also this forum is an eye-opener. So I would request Indian Academy of Neurology to continue this type of discussions in the future also, so that it will be very helpful and it will be very academically, it will be useful for all the practitioners. Thank you, sir.
Oh, thank you, ma'am. Thank you, ma'am. So I think probably before we end, we can take one quick sentence from each of the panelists regarding the movement disorder treatment. So maybe a quick 1-2 liner from each of our panelists, like what are the treatment options for movement disorders? So maybe starting from Ajit.
So above age 65, Parkinson's disease, start them on levodopa. Below, start them on a D2 agonist and slowly build up. And then when once the requirement comes, add levodopa. That is my take home. Don't use triaxiphenidil as a combination with D2 blockers. This is my suggestion
Perfect.
to
Divya can give her take on movement disorder. Now, Ajit has told you about Parkinson. You can tell us about some dystonias or anything about botulinum toxin.
So for the dystonias, we have three options. One is pharmacological therapy in the form of tablet oral medication. Then we have chemodenervation in the form of botulinum toxin, and we have surgical option. If it is a focal dystonia, the first line choice will be botulinum toxin. And if it is a segmental or generalized dystonia, depending upon the patient characteristics, you can go for drugs, and in refractory cases for surgical options like deep brain stimulation, or in some cases in resource limited setting for lesioning surgeries.
Very good. So Kuldeep can answer about the advanced therapies quickly as already he has done.
Yes, sir. So I think when the go for advanced therapies, not just by numbers, only if the patient is having a very bad quality of life because of the Parkinson, then only patient need to go for advanced therapies, because these are not disease modifying, they are just symptomatic therapies.
Very good. So I think Divya, Ashish is there. If Ashish is there, we can take his talk.
Ashish, you're there? Ashish, if you're there, I could share your slide.
I'm seeing him there, ma'am, but
Yeah.
not-
If you want, I think he's trying to share his slide.
yeah, he has started sharing.
Ashish, I think
Ashish, if you could
you
unmute
need
yourself.
to unmute. Unmute, please, Ashish.
Yeah, is my voice audible?
Yes,
Yes,
yes.
yes, perfect. Please go ahead, Ashish.
Okay, slides are visible, no?
Yeah, it is starting to share your screen. It's not
Okay.
visible yet.
Yeah.
now
Yes,
it's
Yes,
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 it's
we can see your slide.
Okay, okay. I'll straight away dive into the topic because of the
yeah,
limited
please,
time.
please. Go ahead,
And
Ashish.
quickly, so I refer to a movement disorder specialist. Let us first understand that the specialist is the one who has taken a deep training for a longer duration, or the clinician who has enough experience to know the nuanced motor signs, to know the phenotyping, to know the pattern of the movement disorders. That is why we would like all of you to refer to a specialist. Now, why this? If you see the data, autopsy proven pathological studies have shown that almost 75% of the PV diagnoses were not accurate. And that accuracy increased when the movement disorder specialists were given the cases to assess, that rose to almost 80 to 85%. And the specialist for this advanced therapies that can be assessed by a movement disorder specialist like DBS, apomorphine, or Botox. These patients, when they're seen by the experts, it is shown, data shows that the hospitalization, like visits to the emergency ER department, is almost reduced by 18 to 20%, and the fall percent is reduced by almost 30%. And we have to understand one thing, even though the prognostication in terms of survival years that could vary from PD to PSP to MSA, but when the patient knows the real truth, they are ready to accept, and they want to live the life with the quality. So we can give the various therapies to prevent falls, to prevent aspiration, and prevent pneumonitis and early deaths. And also, because of these assessments, even the caregiver strain, the studies are showing that it is reduced by 25%. So, in all, it is improving quality of life. So, we know which are the types of movement disorders. What are the red flags? We have to understand that rapid progression over months, something like a subacute or autoimmune movement disorder, that could be the rapid progression. A drug-induced movement disorder would have a rapid progression. We know early falls, that is within 3 years, is a sign of PSP, high chances of PSP. Poor or absent response to adequate levodopa. So when do we say it is adequate levodopa? It has to be at least 1000 milligram for 4 to 6 weeks, not a lower dose or the lower duration. Then early severe autonomic dysfunction like in MSA, early dysphagia dysarthria in PSP and MSA, early cognitive decline and hallucinations like in dementia and Lewy bodies, vertical gaze pulses like PSP, again axial rigidity more than peripheral rigidity like in PSP. Patients can have only gait freezing as the presenting symptom that could be a PSP variant or primary progressive freezing of gait. And vertigo whether it is Parkinson's disease or it is video is you see carefully strikes on the right side. The question strikes
I think Ashish is very, the connectivity is quite unstable. So I'm not sure. Ashish, are you there? So I think the question which Ashish is trying to answer is we had taken that almost in the panel discussion, Divya. Hello. Divya, you have to unmute.
Yeah.
So
Yeah.
already, I think we had
Yes.
taken that question. I think I think he's trying his best. Somehow the connection is not working well from his side.
Yeah.
So maybe I think we can just wind up. Before that, I would request panelists if they can have one question which has come up, like how to address giddiness in atypical Parkinson disease. So maybe to start with, Ajit or Divya can take up that. So, giddiness in patients with atypical Parkinson. So, how to address that? That's the question.
Okay, giddiness. First of all, try to identify what is the root cause. Many a time in MSA, giddiness can be a presenting feature mainly because of the orthostatic postural drop which is happening. So, if it is due to that, identify at the OPD level whether there is a pressure drop. And if that is so, the first will be non-pharmacological, like added salt in diet or salted drinks, and see if the postural drop is linked to use of levodopa. So if that is so, you can fragment the dose of levodopa and give it at a staggered rate. So these are the options which are there. If your non-pharmacological methods are not working, then the option of using midodrine comes, or low dose of fluorocortisone at bedtime. Maybe half tablet of zero point 0.1 milligram can be tried at bedtime. So these are the options for uh, orthostatic postural drop in a MSI patient. Sometimes some of these synucleinopathies and tauopathy patients can have a new onset of vestibular migraine as the initial non-motor phenomenon in these patients. So that is something which you need to keep in mind. So vestibular migraine can happen as a non-motor feature in both in tauopathies as well as synucleinopathies. If that is so, we need to address that with the anti-migrainous medication. So these are the two ways by which I can
I think
suggest.
I think Divya has already shared this a note, a word document which is highlighting the points which Ajit has told. And Divya, you want to give a quick comment on this?
Sir, actually, first line in orthostatic dizziness management or orthostatic hypotension management is non-pharmacological. Sir has already described in detail. One thing I want to add is, I don't know if I missed, that is when patient stands up, they can use some counter maneuvers before standing up. So this includes some isometric hand grip or stretching of the foot or crossing of the foot. And so these will help to reduce that venous pooling and improve the orthostatic hypotension. They can always carry some rescue water that which they can take before they are getting up, and important things like medication management and which can cause hypotension sir has already covered. And once these are not effective, then we go to pharmacological management, and along with that we have to also monitor if they are on pharmacological treatment for supine hypertension.
Very good. So I think what I would like to summarize is probably see dizziness first. Consider it that it is a chronic disorder. So for whatever is causing giddiness, like see the fluid intake, see the hemoglobin, and then of course the drugs, which are always the culprit, which Ajit and Divya has very nicely highlighted, and then of course the disease. The disease per se, vestibular dysfunction, is not something which is quite commonly seen in these patients. And then of course the orthostatic hypotension, which has been nicely dealt with. So these are how we can approach. So I think that and very nicely answered by Ajit and Divya, and we can see if Vaisak is still there.
Yeah.
Sir, I'm here. I'm here.
Not Vaisak, sorry. Ashish, sorry, Ashish was presenting, na? Ashish, you're there?
I think Ashish, if you want to put up the last slide, like when
Yeah.
would you refer to a movement disorder specialist? If you are there, we could just.
I think he has done a very hard work for all these presentations. Somehow,
There is one this patient I would like to show that
yeah,
this was
please,
the
please.
patient thought to this was the patient thought to be as GBS. We treated with MPS and then.
So I think probably the connection is still very unstable from Ashish's side. So I think we can just take up the last slide, Ashish. If you can just show your last slide, and of course tremors, as you are nicely showing, probably in patients with peripheral long-standing or significant peripheral neuropathy, and you have treated that GBS patient. So these are all very interesting cases he was trying to show us, but unfortunately the connection is not working. So maybe I think Divya, you can call it a day now.
Yeah, this was what Ashish was trying to show actually. When to
Yeah,
refer
yeah,
to
yeah.
a movement disorder specialist was
Great.
identify the red flags early.
Yes.
Mixed or atypical disorders always need specialist involvement. PD patients with fluctuations or dyskinesia should be referred early. Botulinum toxin treatable dystonias cases are best managed with a specialist center. And functional disorders need a positive diagnosis by experts, and hence, which you suspect, please refer them to a neurologist. An early referral saves mobility, prevents disability, optimizes therapy, and dramatically improves the patient and caregiver's life. So that was Ashish,
Yeah,
what he wanted to come.
we just keep his last slide, Divya, and I think the last point he wrote there was perfect. That early referral, and that is what I think we have been discussing, and Ajit also discussed this. So we request the physicians that probably an early referral and a program, a treatment program from a movement disorder specialist or a neurologist. Probably will be done, and then of course the patient can be followed locally with the physician in charge, and intermittently maybe 3 months or 6 months they can take help from the neurologist or movement disorder specialist, so that the management plan doesn't get haywire. So I think that is the best way, because early referral is something which probably will save lot of things.
Yeah.
Why?
So I think with that we can conclude today's program.
And I think
So
Ashish. I think we are unfortunate to see all the hard work you have done. So we are really unfortunate to miss you. And next time I think we will get you back. So yes,
yeah.
please conclude, Divya.
Yeah. So I think so. Now I will just stop or finish by thanking everybody today. I would like to thank the IAN for giving us this forum under their aegis for the movement disorder subsection so that we could conduct this program today. I thank all the speakers, Dr. Sneha, Dr. Adrish, Dr. Ashish, Dr. Vaishag, all of them who have put really hard work to put this their presentations together for the benefit of all of us. I also thank the expert panelists, Dr. Ajit Charian, Dr. Neema Vikarthikeyan, Dr. Divya, and Dr. Kuldeep Shetty, who have virtually added significant amount of toppings to today's program. And I would definitely and very importantly talk Dr. Neeraj Kumar, who has been my co-host in this program, for his constant support and the inspiration for putting forward this program. And a special thanks to all the delegates. We in fact had 102 delegates at one point, especially physicians and psychiatrists who were the core and strength of this program, because what we wanted to convey that they are one of the most important and the first contact points when it comes to patients, and we are all here for our patients. So I think they are part of an integral part of the team for patient management, especially with close follow-ups, as well as and the neurologist or the specialist cannot have a close follow-up. It is them who are very closest to the patient and who can identify when things go wrong. And it is very important that they are well aware of these conditions for a prompt referral. And also the psychiatrists who are very close to the neurologist, for almost all the neurological conditions have a very significant psychiatric comorbidity, and they are essentially part of the team. So I think with that, we can conclude today's program. And it has been a wonderful 2-hour session. And thank you all for your presence at this time of the day. Thank you very much.
Thank